Good afternoon all, and thank you Dr. Rohit Saxena sir for inviting me for this speaking on optical correction, uh, optical intervention. So optical intervention for retardation of myopia progression, and if you look at what is myopia, everybody sitting here knows what is myopia. When there is eye as accommodation at rest, when eye focus, it focused on retina, but if it doesn't, because of elongation of ball, that can be a blurred vision and what we call is myopia. So if you look at mechanism of myopia, usually higher lag with near work amongst the myope leads to hyperopic defocus, leads to cue for the axial length elongation in turn. So whenever there is myopia, you can see that whenever we do the single lens correction, this puts the image back on the macula, but the rest periphery will be a hyperopic defocus. So whenever there is hyperopic defocus, that is the cause for the axial length elongation. So what is an ideal which can cover the complete focus on the posterior part of the retina. So whenever we talk about, Dr. Rohit sir has said everything, and whenever we are talking about retardation of myopia progression, lifestyle modification is the first important part, pharmacology and optical intervention. So when we look at the optical intervention, we have a lot many options available, especially for accommodative lag. We have bifocals and simple progressive addition lenses, and to treat the hyperopic defocus, there is a defocus theory. We have Hoya Myosmart, SLR Stilet, Zeiss Myocare and Nova horizontal PAL, and contact lenses, of course, lot many available like MySight, Ability AccuView, multifocal and Ortho-K. So let's talk about bifocal and PAL. We have this study, the bifocal actually has got reduction in 1 and minus 1.25, you can see here, but no replicated in other studies. So still it has got effect. If you look at the PAL COMET study says that it is best with kids with esophoria and large accommodative lags. So it corrects 0.64 diopter treatment effects over the 3 years, and lot many studies again have done, but not clinically relevant. So lot many studies for bifocal and PAL has been done. What are the pros of executive bifocals? It is really inexpensive. Familial concept to parents may help with reading like binocular vision function and accommodative lag, combined well with higher doses of atropine, but it may not be referred for spotty kids, and effect wise it is little below advanced DIMS and Hall technology. So let's look at defocus theory, which is first one is DIMS technology, which is defocus incorporated multiple segments. Here there is 9.4 millimeter clear zone is there, and surrounding that 33 millimeter peripheral zone, which is responsible for creating the myopic defocus. In this honeycomb, if we look, each 1 millimeter has got lots of lens slit of plus 3.5 diopter. So if we look at one pupil size area, there are two areas, defocus and focus, and both are 50-50% in. So this has got a densely within this honeycomb. So if you look at the animation of this is a clear zone and this is a treatment zone which comes for the DIMS technology. And how does it work? When we put the lens, it clears the defocus and the peripheral retina. There are lot many lenses available which is ranging from -10 and cylindrical -4. So again, there's lots of studies have been done for this DIMS technology, 60% efficacy and 70% children progress less than 0.25 diopters. So what are the pros of DIMS? Longest myopia control spectacle study, that is 6 years. Average cumulative myopia progression is less than 1 diopter. Average axial length elongation progression is 0.6 millimeter in 6 years in DIMS study, and no rebound effect as compared to the initial 2 and second and third year of study. It is definitely very costly. Depends upon measurement of monocular pupillary diameter. May have to select the frames sometime from the adult section. May have to compromise for little bit part of treatment donut, and quality of the vision may not be acceptable for older teens and kids, which usually plays the spots. So let's look into Hall technology. Again, there is a central 9 millimeter of clear zone, 11 rings of 1021 contiguous touching to each other aspheric lancelets, which is of 1.12 millimeter in diameter, and it has got same geometric lancelet in the same ring, but each ring has the different geometry. So space between these two is used for the clear vision, distant vision, and this in turn together causes the volume of defocus. So this is simple, a small innovation. It is 1021 lancelets, concentrating ring, 11 rings, and it gives the clear vision. So this volume of defocus actually has peripheral focus and simultaneous focus. So if we put the normal single lens, that is a criteria for, that is a activity for axial length elongation, but here it is two contrasting signals falls on the retina to correct the emmetropia, and again falls in front of the retina to create the myopic defocus. So again this is available in lot many numbers. Lots of studies for Hall technology is done, that is, but mainly these studies are for 2 years. This is the result for myopia correction, axial length growth correction, even that is a part-time versus full-time study, rebound effect, effect on reading speed, effect on visual acuity and function, effect of halt on retinal shape and choroidal thickness. So lots of studies are available. I do not have any financial interest for this. When we look at the pros of halt, excellent efficacy, premium product, even profit center for the practice, and flexibility in frame selection. Again, no reading aid is there, it's costly. Quality again is not too much acceptable for the kids who play sport. So third technology came is CARE technology. It's a cylindrical annular refractory elements inspired by ortho-K principle, ring-like imprints on the cornea following ortho-K, alternating defocus and correction zones expanding towards the periphery, which this is a Zeiss myopia CARE technology. It has got two pillars. Pillar 1, there is anterior pillar which has got CARE technology to deliver the stop signal, and there is a pillar, posterior pillar, which is for clear focus design for correction of the refractive error. So this in turn, this is the detail that has got clear zone, functional zone, height and width of the CARE, distance between microstructure and size of the clear zone. This is intended myopic defocus, and usually it is good for maintaining clear vision in all gaze. And again each lens has fill factor like functional zone versus clear zone. This Zeiss myopia has 0.5 fill factor, and that is optimum myopic defocus is plus 0.5 to plus 5. So this in turn, when the light focuses through passes through the elements of the lens in refractor, this causes the forms of caustic, and then in turn creates the blended distribution of myopic defocus, that then it acts as a EDOF lens. So we can just compare it is a extended depth of focus, and it comes in two parts, softer version and the harder version. So myopia Zeiss also, there are lots of study, but they show a 30% efficacy, no clinically significant. The fourth one is horizontal PAL, which is from Nova, that is a horizontal progressive addition lenses. There is not much of a study available for that. So spectacles are an integral part of any myopia control strategies nowadays, and let's look at the contact lenses. So we have option is multifocal contact lens, that is a simultaneous correction for foveal vision and myopic defocus. So again there is a concentric ring as distant zones of the alternating distance and relative addition power. So we can see there is a treatment zone and the correction zone, usually approved by, this is a MySight Cooper vision lens, which is only approved lens by FDA. I don't have any financial interest. Central distant correction and with peripheral addition is available. So this is the way how MySight from Cooper vision works and creates the myopic defocus. So MySight efficacy has been again studied for 109 children, and it has shown 59% reduction in refraction and 52% reduction in axial length growth. So this is another newer lens is pre-clear lens, which is not available in India. So it is a daily wear lens, monthly replacement is possible, and clear distance D lens with 1.5 millimeter concentric optic zone. Variable aids are available and both have toric options also. Another lens available is VTI natural view lens, that is again EDOF lens. So again it is a daily disposable lens, and other options, lots of options. Swiss lens, only I have 2-3 slides. Swiss lens, Essentia Milo lens, which all are not available in India. So when can we start this contact lens? As soon as child can handle true contact lens wear. Talk to the parent about myopia management, as Dr. Rohit sir rightly said, when you suspect pre-myopia. And myopia can continue to progress up to 50% stability, usually at age of 15, 75% stability at the 18. So you can switch to the single vision lens. And again, the ortho-K last technology available, which is a reverse geometry technique, works on reducing peripheral hyperopic defocus. So again, that we all know how does it work, increasing peripheral myopia defocus. And again, the 2 years RCT has been done. Meta-analysis says that 0.18 millimeter reduction as compared to the normal control over period of 2 years. Rebound still not known, accelerated progression after this, and corneal infiltrates and the infectious keratitis is the primary concern when we are giving ortho-K, because microbial keratitis in children 13.9 as compared per 10,000 patient as compared to adults, that is 7.7 as per 10,000. So again, studies, you have to, this study says that you have to weigh benefits versus risk whenever you are prescribing. So deciding between ortho-K and multifocal lens is simple. If this 9-year child, refraction is this and keratometry is this, we can give multifocal, no RK, orthokerato, because of flat cornea. So you have to take care. So this is simple comparison. We have created all options available, and there is one Cochrane study, 6772 children have been created. What is the moderate certainty evidence and what is the certainly evidence progress. So in conclusion, patient and child education, outdoor activities, combination of pharmacological with optical seems to give more benefit. And how do we just judge the success? Positive, meaningful impact refraction on axial length and refraction, no rebound on scissors, and minimum negative impact on visual function and evidence of beneficial effect on anatomical. We all do in one capsule, still some children will cry, some children will laugh. Thanks to my teachers, thank you all for patiently listening and giving me 1 or 2 more minutes. Thank you.
Thank you for compiling all the options that are out there. But as was said, we really don't know the long term, still keep going back and forth between lenses. So I'd like our expert panel to give their experience on what they feel works well, or how they would manage.
Yeah, I think if you ask me, there are different reasons for this myopia progression, right? So she talked about first, simple PAL lenses, right? Or even simple giving bifocals or multifocal, the lower segments. Then we talked about, the different type of, the lenses where we can change the, the peripheral hyperopic defocus. And then we talked about induce the myopic defocus. And then, the options of various, the contact lenses. Having the same reason, we are trying to reduce the hyperopic defocus. So all the patients, they do not fit into one category. So you need to find out, this particular patient, which is the primary cause for his, the axial elongation. So depending upon that, many times I have come across when I started using pharmacological therapy, they showed very good response for, the year and a half. And then I realized, okay, this particular patient also has, the hyperopic defocus. So these are the candidates. No one therapy is, the rule of thumb. We have to, keep finding out what is the primary or predominant cause, and then accordingly you have to take, we do have a lot of options. We have to choose smartly what is the best and then take forward. If we talk about even pharmacological therapy, nowadays we know that, the paper coming from US saying that it doesn't work in children in US, and we are using it since last 2.5 years. So we have seen that one-time dose probably it's a dose dependent. So I do start in my practice sometime 2 times in a day, like morning and evening dose, and we need to look at like whether does it works over a period of time. But as we discuss and we always debate on this, that there is no one point solution. We have to keep taking a decision smartly.
I have a question for Rohit sir. I would like to know about your preferred practice. When you give the specialized classes for treating myopia progression, do you combine with low dose atropine or only you are preferring glasses?
So I would always start one therapy at a time, unless it's a very rapid progressor, and even then I would want to know the effect of one treatment. So I always correlate it with like glaucoma therapy. I mean, unless the pressures are very, very high, you would start one drug at a time, know the impact, whether it's effective or not, and then decide whether you want to supplement or replace. So whether I start atropine or I start refractive optical treatment, I will always keep one intervention, follow up for maybe say 6 months, see the impact on the refractive error change and the axial length change, and then take a call on whether I feel a supplementation. If it's moderately responsive, that means some work is happening, yet I feel he's increasing rapidly, I would probably supplement. But if there is no significant impact on 6 months, maybe I would think of a switch. If it's on atropine 0.1%, maybe I would think of shifting to 0.05%. So that's how I would, grade treatment. Most important thing, know progression, know the rate of progression, so that you know the impact of what treatment you are giving, and subsequently you are in a better position to decide how to do your change in individual child, rather than just randomly taking a call that this doesn't seem to work, let me add that doesn't seem to work, let me put both of them together. So hard data on every child is probably how we can give tailored interventions.
Thank you, sir.
I have is like, yeah, go ahead, sorry.
Acceptance. Sorry, what are better? The single vision
Acceptance, yeah.
spectacles. There is no doubt. There is a little bit of, some children do find it a little, very perceptive children. So you're playing with light, you're cutting, it's like multifocals, you get better and better, but the best vision is by, a clear lens, a single vision lens will always give you better vision. The moment the child looks through the side with these spectacles, you are cutting off 50% of the light from going onto the fovea. So the quality of the image is going to be less. So children, perceptive children will have a problem. Sometimes children have a problem if the lens, if the because it's from the mid-periphery onward. So the spectacle size has to be a little large. Otherwise, what happens is the child starts looking near from the periphery part of the lens for too long, and then again he has blur or vision-related problems, or a decrease in contrast, which has been definitely documented in these spectacles in the periphery. So these are issues that the child has, but as of now, I haven't had any child who has stopped using these spectacles. Maybe the parents are so pushy that, these are very expensive lenses, so you better use them, or else. So maybe, but I haven't had any child who has stopped because of, optical reasons per se.
Actually, I have an experience of about 60 patients. I've given my DIMS glasses, and they've come for a 1-year follow-up. They are doing quite well, so there is no problem actually. Yeah, with these DIMS glasses. And again, we can always try a combination therapy.
Sir, I have one doubt. Whenever we start these spectacles for these myopic children, what is the dead end? How do you decide? Like suddenly if a patient says after 1.5 years, I want to shift back to normal specs. Like for atropine, there is 2 years or 15 years, whichever is the long. Do we know that when do we stop these glasses? When is there any point when we can really shift them? Stability of these many years, or any such rule with respect to spectacles?
Yeah. Yeah, so I think there are two things, you need to keep shaking the axial length on a periodic basis.
And the refraction.
We came out in a guideline that every 6 months. At the same time, you need to do a peripheral, the hyperopic refraction that you need to, if you have the open field autorefractometer, then same parameter you need to follow, and then see, now after a period of 1 year or 2 years, there is no much change in the axial length and peripheral hyperopia had been reduced, then probably that's the time. But then again, we advise even for pharmacological therapy, the slow
Tapering.
tapering. So same thing is more or less applicable for these DIMS lenses.
How do we taper?
You want to add something, Dr. Rohit?
So really tapering is something that has not been discussed with spectacles.
Correct.
But there is a time limit. They say that the child should be wearing these glasses for say 12 hours at least during the course of the day. So subsequently you could, if child is uncomfortable, you could think if everything is stable. Even for atropine, I would say there is no end point. I mean, I have a child who's been on 5 years now and I'm kind of trying to taper them off. Some of them who progressed after tapering and stopping, I have switched to spectacles. So there is no end point. So there's no end point to myopia therapy. We can never guarantee that they'll not progress. We've had young adults in their 20s come with progression of myopia. So it's a little challenge right now. But for all interventions, as we'll, I think, go on and discuss, it's probably individualized, tailored approach. If he's progressing, you may have to go back. You may have to, like tapering for atropine, we know, so for this from 12 hours, you can bring down to 6 hours and then go. But there is, this is just, I'm giving you, just a clinical experience. There is no at all study or information in the domain that we can talk about.
I have a very basic question. When do we start? Do we have to document an axial length progression and then start pharmacological therapy, or can we start it empirically and or the spectacle therapy, the special?
So any myopia therapy, you need to identify the disease. The disease that you're treating with this, any treatment we're discussing is progressive myopia. So we need to document progression, we need to document rate of progression. For two reasons. One, because then only we confirm the diagnosis of progressive myopia, and two, whatever intervention we give. So only then will we know how much impact we have made. A child who was progressing with 1 diopter a year, we bring him down to 0.5 diopters a year, great impact, I can supplement. A child who was increasing with 0.5 diopters a year, I bring him down to say 0.3 diopters a year, the impact is that treatment is not working. I should switch the treatment and look for, optical versus pharmacological, whatever was working.
Yeah, so we'll take the discussion